Okay, so good evening, everyone, and welcome to session 8 of our Practice Manager Networking and Education series, Coordinator Veterans Care, the CVC program. My name is Katrina Pilbeam. I'm the Manager of Education Capacity Building at Western Victorian Primary Health Network, and I'll be your facilitator for this evening. Just 1 second, we'll just postpone that. I'd just like to start by acknowledging the traditional custodians of the lands and waterways in which we're meeting today. I'd like to pay my respects to both elders, both past, present, and commit to working together in the spirit of mutual understanding. We recognise their diversity, resilience, and the ongoing place that First Nations people hold in our communities. Some upcoming events that we've got going on at Western Victorian Primary Health Network at the moment. In October, we're starting a Emergencies in Primary Care series. They operate on a Tuesday morning at 7:30 and they run weekly during the school term. We've got some webinars coming up, Moving Together, so promoting activity in primary care, Cracking the Code on Dry Eye, and our very popular Better Billing webinar series that looks at all MBS items and different topics throughout the year. We host about 4 of them a year, so they're quite popular. Our face-to-face and hybrid Practice Managers Networking and Education series, they're still continuing, and at the end of the year, we'll celebrate with a networking event. We've also got our primary care conference coming up in October. Now, we've had an absolutely overwhelming response to our conference. Registrations are only open for another 3 weeks, and we have about 40 spots left. So if you are interested in coming along, we've got Samuel Johnson, and he's speaking on precision medicine and some work he's doing, obviously, with his Love Your Sister Foundation. Paul Pritchard, who is a climber and disability advocate, speaking on dignity of risk. We've got some comedy from Dilruck, which a lot of people would be familiar with, but we've also got Dr. Paresh, who's presenting on the Medicare changes. We've got a metabolic management session, future workforce, clinical skills. We've got dermatology and wounds, and a practice management session that's also being delivered by Avant. So it's a really good program over 2 days, and it's free to attend if you're a member of Westvic PHN. And if you're not a member currently, it's an application form and it costs you nothing to be a member. So it's hosted in Ballarat. So it's a really good one to look out for. Certificate of attendance. So if your name is not displayed correctly in the chat, we're unable to recognise you, so therefore unable to give out your certificate. So we need you to either type your correct name into the chat or rename yourself. And I would like to hand over to Kate tonight, who is presenting on our topic. And Kate's a registered nurse working in primary care. So thank you, Kate.
Thanks, Katrina. Well, as Katrina mentioned, my name's Kate. I'm a registered nurse and I have been for about 25 years. And I've been a practice nurse for about 17 of those years. I currently work in general practice and I also do some work for APNA as well. I've worked closely with the coordinated veterans program, case managing up to 60 clients in the community at any one time, and set the CVC program up for several clinics across the Geelong region. We need to go to the next slide, Katrina. Tonight's discussion aims to unpack the fundamentals around the CVC program and how that looks in the setting of general practice. We will discuss the best utilisation of staff members, a shared practice team perspective, and how we can work together as a coordinated team to provide improved health outcomes for our veterans in the community. Of course, ideally, this will equate to less hospitalisations and emergency department presentations. By identifying key criteria, we establish firstly if a veteran is eligible to participate in the program. We will also discuss relevant item numbers and how the chronic disease framework can be coupled with CVC billing cycles to achieve the best financial return for practices. Next slide. So let's break it down. What actually is the CVC program? How does it work, and what do we have to do as a general practice to implement this program correctly and for the benefit of everyone involved? How did the program begin, and what changes have been made over the years? And next slide. The Coordinated Veterans Care Program was developed by a research group at Flinders University in South Australia and became live in Australia in 2011. Fundamentally, the program aims to reduce the risk of unplanned hospitalisations. This program was also designed to improve the health and wellbeing of veterans of the Australian Defence Force through a team-based approach involving veterans, their GPs, and care coordinators who are typically practice nurses, working together to develop and implement comprehensive care plans. The aim of the program also encompasses the fundamental goals of improvement to quality of life and providing patients with the assurance that they have another advocate in their primary healthcare team who has direct access to their GP. I believe this is a great point to raise with the patient when first discussing the program, as many find this a reassuring point to take away. When many patients have difficulty accessing GPs at short notice, it's great for patients to know that they can at least leave a message for their care coordinator if they have any pressing concerns, and that then this can be triaged as required. Additionally, the care coordinator can often discuss any concerns with the GP and come back to the patient with a plan. Additionally, the care coordinator may be able to have the scope of practice to work through concerns with the patient without requiring the GP's time at all. Next slide. So in conclusion to that overview, in the environment of the general practice, the CVC's program main goals are to achieve holistic coordinated care at a primary healthcare level. The program also aims to empower the patient to improve their health literacy and become an active participant in their own health outcomes. The CVC program enables regular visits to occur that are bulk billed and encourage and support the adaptation and integration of other chronic disease MBS item numbers such as 965, 967, 10997 and health assessment item numbers into the greater cycle of their care. The improved health outcomes are achieved by ensuring regular visits, both face-to-face in a clinical setting, via phone and at the patient's home if circumstances allow. The CVC program encourages the DVA client to take a self-managed and informed approach while the GP, extended multidisciplinary team and the care coordinator manage the client's health needs using a person-centered approach. Next slide. The CVC Toolbox is an excellent resource and learning tool. We might try and click on the live link in just a moment. I'll just finish speaking about this slide first. It's very important that a consent is documented in the patient's notes by the patient's regular GP. When I say consent, I mean consent to participating in the program. The GP, the patient, and the care coordinator will then collaborate to develop an individualised and comprehensive care plan that aims actively involved in the client, in their own care. Actually, that link we're just going to pop in the chat, aren't we, Katrina?
That's in the chat for people to access.
So we won't open, we'll just leave that link in the chat. So next slide. So what is the care coordinator's role? This role may include, but is not limited to, referring, connecting and liaising with allied health services, assessing patients for goods and services in relation to continence needs, and order on the patient's behalf, accessing CAPS funding, access the provision of lifestyle aids, assisting with my aged care, open arms social support, and communicating with family members and carers. This can be achieved through regular contact and also providing the opportunity for the veteran to contact their coordinator with any needs or concerns. when we're identifying patients for the Coordinated Veterans Care Program, we can do this through best practice. It is a little bit limited. If everyone, or if you've got POLA, that's a fantastic way of identifying your gold card holders, which we'll go into in a little bit more detail in a minute. That image, Katrina, we're going to share at the end of POLA. Yeah. Next slide. So moving on to eligibility, here we will identify the key tasks required to successfully enrol patients onto the CVC program at your practice. Next slide. In my experience, most veterans experience some degree of PTSD, and this is a reasonable diagnosis to fit the criteria for eligibility to the CVC program, as long as it has been documented as a diagnosed condition within the patient's medical history. Other eligible conditions may include, but are not limited to, chronic conditions such as type 2 diabetes, ischemic heart disease, chronic obstructive airways disease, and so on. So any chronic condition is suitable for a patient to onboard onto the CVC program. And considering that most of those patients are older, it's fairly unusual that they don't have something that will allow them to join the program. Also, just to note, because a person is a white card holder doesn't necessarily mean they qualify for the CVC program. At the moment, they are only eligible to participate at this stage if they've been diagnosed with a mental health condition that has been associated with their time in service. Information can be found on the DVA website under the CVC program tab to identify the chronic conditions that allow the patients to be eligible to get onto the program. Next slide. We'll now move on to what can and should a comprehensive care plan include. The next slide. There are templates available in the CVC toolbox. However, in my experience, they have a little bit too much information for the patient. They're a bit lengthy and wordy, and the patients struggle with the amount of content and format that's provided. So I would recommend a condensed version of these care plans, focusing on smaller SMART goals to best engage with patients. An example of a simple SMART goal could be something like, in order to maintain mobility and independence for an 80-year-old lady living at home, may simply be just walking to the end of the street 3 times a week. These goals are developed together and with the agreement of the client and need to be realistic. The plan may also include such information as other care plans do, like a list of conditions, medications, and multidisciplinary team members and their contact details. The document should act as a reference point for both the patient and the care coordinator at each meeting, and progressive notes can also be included in the plan as well. I find the progressive notes in the plan quite useful because you can see just that what's being achieved and what needs to be adjusted. So when we meet with the patients, it gives us the opportunity to discuss progress, the relevance of new goals, and the progress of existing ones. We'll go to our next slide. So we'll move on now to billing, which I'm sure everyone's quite interested in. Here we will identify item numbers, the relevance of the chronic disease framework, and how these can create key dates to coordinate optimum care for your DVA patients. We'll go to the next slide. Before initiating the program for an individual, it is important that all these points are clearly documented in the patient's history, just on the slide I'm referring to, including their consent. And the consent has to be done by the GP, not the practice nurse. This consent should be documented by the patient's regular doctor, which is what I just said. That is the main point of contact with the GP in the CVC programs. So aside from that initial visit where you would have a formal appointment with your GP, the rest of this program is nurse-led. We need to ensure that veterans meet these criteria. We have undertaken a comprehensive assessment, and in an ideal world, we're able to visit the patients in their own home to get a true understanding of their circumstances. I know since COVID, this has been less popular. You certainly still run the veterans program without going to the veterans home. But I just think we get a better understanding of what's going on when we can see a patient in their own setting. With the information on board, with the collaboration of other team members, we are then better equipped to develop a care plan that accurately addresses the client's individual needs. And next slide. So the period of care is 90 days, and that is the billing intervals. The UPO3 and UPO4 cannot be submitted to Medicare until after the payment period is completed. For example, 90 days plus 1 day for the date from the date of service. It's a good idea to set up a spreadsheet in your clinic that both admin and the care coordinator have access to, and a care cycle can be followed by both team members to ensure that criteria is being met and the billing's up to date. My experience is dedicating one admin person and one nurse to this role, and they can work together as a little team. Seems to work really well. And we'll go to the next slide. So to calculate billing accurately, there is a great live calculator available in the CVC toolbox where you can enter the date of service and it will project the billing dates for the next 12 months. So you can see a little screen capture of that on the slideshow now, and it just makes it so easy to drop those dates in. These are important to include in your spreadsheet, along with other tasks such as GP, CC, MP plans and reviews, referrals, health assessments where applicable, D904 referrals, and ordering consumables such as continence aids. The Country Care Group provides a great service to the program, allowing the care coordinator to access and order lifestyle aids for the patient. Simple examples of these might be large font clocks that display day and time. So if people are living on their own and they're not getting the paper, they know what date it is and what day it is, and they're not seeing people. It just gives them a bit more perspective. And then there's practical things like, I mean, there's limitless things, but, you know, popular things are like sheepskin comforters and clothes areas that, you know, they don't have to lift up high or reach up high to, and yeah, lots of different things, retractable hose reels that they'll come out and install for the veteran. And that's all covered under the Veterans Care Program. Independence Australia has a dedicated veterans portal for gold card holders. Oops, don't know what happened then. Sorry, I've just lost my screen. Here we are. Sorry about that. Yeah, so Independent Australia has a dedicated veterans portal for gold card holders that can be accessed by the care coordinator to supply a patient with funded continence aids and other continence support products. We'll go to the next slide. Now, this is a long one. For the purpose of the use of item numbers within a general practice, the relevant item numbers used for the Veterans Care Program are UPO1 and UPO3. As you can see in the table in front of you, an initial UPO1's value is $502.45. The value of the UPO3 item number is $524.35 and can be claimed 4 times over a period of 12-month cycle. Therefore, the total amount generated for patients enrolled in the initial year of the CVC program is $2,599.85 and $2,097.40 in subsequent years on the program. The UPO1 is claimed just once on the initial visit. It's like an onboarding item number where the patient's consent to being part of the CVC program. This should be clearly documented, as I've said in the past, in the patient's notes by their regular GP. Consequently, the UPO3 can be billed on a quarterly basis in a retrospective pattern, as discussed previously, the 90 days plus one. So services and care should be appropriately documented in the patient's file. GP, CCMP, and annual health assessments can be incorporated into the annual cycle of care for the veteran. So when we maximise MBS item numbers from the chronic disease framework, we can add in, for example, your care plan, which is MPS item 965, which is $156.55. We can do at least 2 reviews in a 12-month period. Item number 967, again, $156.55 Medicare rebate. And so the reviews equate to $313.10. A health assessment MBS item, for example, today I've used the 707, it's $313.60, as well as your 109.97. So if you collate all those figures together, you can generate a total amount of up to $3,453 around about in the first year, and then $2,950 going forward. It's really easy to keep track of those appointments on that spreadsheet. And I have found that largely once you get the veterans on board and we organise those times, and they actually really enjoy it and look forward to it. And quite often, you know, we create a really good relationship, and they're keen to come back for their reviews and all those sorts of things. So yeah, so basically $3,000 a year after that first year, so just a little bit less than 3.5. And we need to remember here too that this income that is mostly entirely nurse generated and requires minimal time with the GP. This means the GP is still able to see the patient for other needs and requirements. So obviously if a clinic had, for example, I'm just being I don't know, probably conservative, but 15 eligible patients that had a gold card or white card with a mental health condition, the practice nurse could generate around just under $45,000 a year for their practice. That's based on 15 eligible clients. Yeah, and so, I mean, when you get back to work, perhaps just do a bit of a search on Polar if you've got it, or best practice. You can still do it on best practice. It's just a bit more difficult to identify the gold card holders, and it's pretty easy to generate an estimated income of how much this nurse could generate for the clinic. Next slide. So in summary, the CVC program is predominantly a nurse-led clinic and assists eligible DVA clients to better manage their health and provide a valuable connection with their primary healthcare team. Next slide. We need to understand the eligibility criteria and set achievable goals that aim to improve function, independence, connectivity, and optimise wellbeing. And next slide. The clinical mode encompasses the client, regular GP, care coordinator, allied health services specialists, and community services. We encourage the shared care of the client and welcome input from other professionals to contribute to the holistic care of the DVA patient. Next slide. Key points to take away in terms of practice incentives include a $502.45 sign-on payment, referred to as a UPO1. Ongoing retrospective claiming of MBS item numbers UPO3 and can be claimed quarterly and have a value of $524.35 each. This particular payment are not associated with face-to-face consultations, but rather a continuum of ongoing care coordination provided by the care coordinator, otherwise known as the practice nurse. As previously mentioned, when combining combined with the existing chronic disease framework items, the program works exceptionally well for the practice. And next slide. The CVC program has the capacity to positively impact patient care by providing a structured approach to an individual's chronic conditions and providing continuity and consistency. With the recent changes to chronic disease framework, this program also supports the utilisation of existing staff members. I'm sure there's probably some nurses out there that have I don't know, perhaps hours have changed, or there's been a bit more pressure on the nursing team because of the change rebate. So if you haven't got the CVC program running at the moment, this is a good time to probably bring it up. Next page. So staff training is available through platforms such as Health Pathways, DVA and APNA. They are generally low to no cost, and a lot of the knowledge that practice nurses already have on board in managing chronic diseases is already there and relevant to the care coordinator role. Next, I think we're nearly done actually. So yeah, that's about it in terms of what I've got to present tonight. I think I might hand over or invite Katrina to perhaps have some questions if anyone's got any questions they'd like to ask. I also will be giving my details to Katrina, sorry, my contact details. So if anyone wanted to contact me or need some help in their practice, just
I will end the webinar now.
Thank you.
And thank you, Kate. And
thanks everyone.
It was a great presentation and really well done. So thank you.
Thank you.
Thanks everyone. See you later.